Welcome to today's class on Squint. Welcome to today's class on Squint. I would like to introduce everybody to Dr. Sapna Jain. She did her undergraduate and post-graduation from Osmania Medical College in Hyderabad in 1998, following which she did her senior residency in Delhi. Then she pursued her fellowship in pediatric ophthalmology from the famous Arvind Eye Hospital in Madurai, and she's been having her private practice in Delhi since then. So, I'm
So,
sorry.
shall we start? Thank you, Dr.
Yeah,
Madhurima. You
kindly
have
start.
been putting in so much effort in this group, and we really need to thank you for that, and even for organizing all these Zoom talks. Thank you.
True. It's really my pleasure, ma'am.
Yeah, so we start today's topic on basics of Squint, and everyone is free to even interrupt me in between. And if I go at a fast pace, you can even ask me to slow down. So this is a very basic examination, very basic talk, which I have tried to incorporate as much as I could, making it easy and not confusing. So I wonder if anyone has seen Monster Inc.
Yeah.
Yeah.
I've seen it's a beautiful one.
Yeah, so our Squint is like Monster Inc. It just scares you. And the more you get scared, it scares you further. So let's try not to get scared of Squint. So before we go to the main topics, let's see what are the terms and some abbreviations that are used in Squint. AHP, CHP, I'll just read the full forms. Anomalous head posture, compensatory head posture, corneal reflex, cover test, oculomotor, ocular movements, prism cover test or prism bar cover test. And PBI, PBO is prism base in, base out, base up, base down. These are the terms that we use commonly. Short forms you'll find in any of the Squint sheets. ET is intermittent, ESOs and RET, LET, AT. So accordingly, exotropia, right? Exotropia. So we don't use divergent squint, convergent squint. We use ETs and XTs. NRC is near point of convergence, near point of accommodation. RAF is RAF ruler. And MR, LR, SR, you know, all are the muscles. And DVD and DHT are dissociate vertical deviation and dissociate horizontal deviation.
Ma'am, what is SMP?
Simultaneous macular perception.
Okay.
Yeah.
Yes.
So the terms are the terms that we use in Squint: primary gaze, the 9 positions of gaze, ductions, versions and vergence, phorias and tromias, comitant and incomitant Squint, primary deviation and secondary deviation. I'll come to all in the further in the talk. So ductions, we always remember it's a uniocular movement. When we call of ductions, it is like in one eye. Here I have showed you in a right eye: abduction, adduction, primary position, depression, elevation, elevation in adduction or depression. So when we talk of versions, it is a bilateral simultaneous conjugate movement. Primary gaze, elevation and depression remain the same. Now we get dextro elevation, dextro version, dextro depression, levo depression, levo version, and levo elevation. Vergence is bilateral, disconjugate, or non-parallel eye movements in which both the eyes move in opposite direction, the convergence and divergence. Now, what is primary deviation and secondary deviation? Primary deviation is in a comitant squint, both are equal. So we cannot make out what's a primary deviation and a secondary deviation. But otherwise, in a paralytic squint, the normal eye is the fixing eye. Then the deviation that we see in the other eye is the primary deviation. And when we fixate with the paralytic eye or the deviating eye, the deviation that we calculate is the secondary deviation. So when we go to squint, how do we first proceed? So squint could be real or a pseudo squint.
Ma'am, can I interrupt you for a while?
Yeah.
Ma'am, regarding secondary deviation, how can you calculate when the eye is not moving at all? How can we fix that eye, ma'am? Suppose in this eye,
No, it will move. It will move. Why will it not move?
in paratic squint, suppose there is grade -4 restriction of the lateral rectus.
-4. -4.
The eye is in adducted position.
Yeah.
So how do we make that eye fix and calculate the secondary deviation?
No, in that case, we are if you're calculating for surgery.
No, ma'am. Not for
See,
surgery. Like when the PGs are not present in the class, they
yeah.
keep
So
asking us.
see,
So,
okay. So when you are fixing with the left, supposing we assume that the right eye is a deviating eye and it has got sixth nerve palsy and it is in the adapted position. Okay.
okay, ma'am.
So we are fixing with the left eye, which is the normal eye.
Yes, ma'am.
So that will not have much movements when you're trying to see the deviation. There won't be cover test or uncover test or a prism bar cover test. There won't be much movement. But now when you make the patient look from the right eye, which is a deviating eye.
Mm,
So according to the Herring's law, there will be excess of innervation going to the left eye. So
correct.
that will produce excess of deviation. That becomes a secondary deviation.
Acha. So we have to cover the non-paretic eye. Yeah, correct. We have to cover the normal eye.
Yes,
So and give them an object of interest.
yes,
So
yes,
in an effort to fix it, the right eye will
yes,
move. It will
yes,
adapt.
yes.
So the angle of deviation will be lesser. Correct.
Will be no with the if with the paretic eye when the patient will fix,
Okay.
this will have go extra innervation because this is making an extra effort to fix it there. So
Okay.
there will be extra innervation, so that becomes a secondary deviation, and that deviation will be more in the paralytic eye.
Okay. Okay. Okay, ma'am. Yes. So we don't have to turn the head like that or anything because eye is
No,
not
no,
moving.
no. You should always be in the primary position.
Okay. Okay, ma'am.
No,
Yes. Thank.
but when that eye is covered, the normal eye, how do we see the deviation after uncover?
Yeah, yeah.
Okay.
Tropias is always like that.
Okay.
Okay. And now we go to the classification of squint, or when a patient of squint comes to you, we divide into pseudo. First, we identify whether it's a true squint or not. And then if it is a true squint, whether it's a latent squint or a manifest squint. And again, in manifest, whether it's a paralytic or incomitant, what we call, or whether it is comitant, which is also known as concomitant or a non-paralytic. So examination of strabismus, initial is a history, and the basic examination that we do with any eye problem when the patient comes, from the history, inspection, visual acuity, refraction, normal ocular movements. Then the more important thing which is pertaining to the strabismus is Mota's test and the sensory test. We'll come to all that now. So history, we start from the birth history. Birth history, taking whether the child is full term, preterm, whether it has any antenatal high risk factors, a low birth weight baby. These patients are prone for more incidence of squint and refractive errors. Then postnatal, any developmental and milestones, and any birth asphyxia, whether any treatment history was there during the admission times, and even from the time of birth till the time of presentation. I always ask whether there has been any admission in that period, whether the child has fallen sick in that period, even if it was not at the birth. Like supposing a high grade fever, the child had meningitis or severe diarrhea, because these episodes are the ones, especially they give rise to exotropias. So these histories are important from when the onset of squint was and whether in that time there was any significant systemic illness. So once we come to the squint, we should always get into the details of onset, duration, whether it's constant or variable, whether it comes occasionally in the day or it is there throughout the day. Any treatment history, whether the child has taken any patching or any surgical history or any treatment history um, related to not only the ocular condition, even the general condition, any drugs which might affect his vision, spectacles, whether the child has been using, any patching has been going on, family history of squint, any history of trauma, diplopia. Diplopia, again, if there is an intermittent squint without without an incompetent squint, also there can be complaints of diplopia. Head posture. The parents can occasionally come and complain that the child always takes a position like this. When he's watching TV, his always neck is like this. In the school, the teachers are complaining he's always having a head posture. And they come with a complaint of nystagmus. They call it as a wobbling eye, shaking eye. We start the order of examination from the observation, visual acuity, and first we find out whether whether the patient has got squint or a pseudo squint. So we need to know the normal we all have is positive angle kappa. That is slightly nasal to the pupillary center and it simulates an exodeviation. So the cornea is there. This is the center. The reflex will be here. So if it is exomorph, the reflex will be more nasal. If it is eso, the reflex will go outside. In a positive angle, kappa, which is normal, the reflex will never be in the center of the pupil. It will be always a little nasal to the pupil. A negative angle kappa, when the light reflex appears temporal, simulating exodeviation, it can also again be normal. A pseudo exotropia. See here, we can see that the light reflex is nasal. The pupil center is here, but the light reflex is here. So you get an epicanthic fold, short interpupillary distance, and a negative angle kappa. My screen is having the pics. Okay. So this pseudo exotropia, you get in a wider interpupillary distance and a positive angle kappa. Always when the patient enters, look for any physical abnormality, any facial asymmetry, any cerebral palsy, microcephaly. All these patients are my own patients. If you notice this child, very subtle, but this had a very small ptosis, which I missed preoperatively. And postoperatively, he had a total drooping of eyelid, which by itself spontaneously resolved in around 15 days. But that 15 days were hell. Next, we go to vision. Before we go to
just a minute, Sapna. In the case of pseudo squint, how do we know that it is because of large positive angle kappa, negative angle kappa, or really a squint? Means we normally see them from the pupillary reflex only, no?
yeah,
If they are
yeah.
very
So
small
the pupillary reflex will be equal in both the sides.
Okay.
See, one is that, and when you do the uncover test, they don't have any refixation movements.
Okay. Thank you.
Equal in the sense the Hirschberg is same nasal or in both eyes, or
Yeah,
in
it should
one
be.
eye
It will be same. It will be same.
Okay, one eye temporal and one eye nasal. ऐसे में नहीं होगा, right?
It shouldn't be there. Until there is an asymmetry in the face.
Okay.
Ma'am, I have a question.
Yeah.
When you say about angle kappa, is it it's very minimal, right?
Yeah.
Or will it be more than
5
50?
degrees. No, it's
That's
around
it.
5 degrees.
That's all. Okay.
Yeah.
Okay, ma'am. Yes. Yeah, like how ma'am asked, even microtropia, you may not have any movement during cover.
Yes. So we do a four prism base out test. So this is
Achha.
another way of testing. If you're not able to test a cover and cover test in kids, so you can, instead of doing a four prism base out basin test in as we do for microtropia, you can do a 10 prism vertical base up base down test. So if there is redirectional movement of the eye, these are also to test the vision. It means that there wasn't anything, and now it has been created by the prism. But if there is, I'll tell you that in the later this thing.
Yes, ma'am. Yes.
Yeah. So before we go in the assessment of vision and details, there are some visual milestones we should always remember. Like we know the developmental milestones of the body, certain visual milestones should always be there. And the commonest one is at 3 months, the child will have a social smile. 2 to 3 months, a child should have a social smile. And around 6 months, 5 to 6 months, they start developing a depth perception. In the depth perception, they will reach out to for the toys, or they will reach out to their own hands. By 9 months, they will start having a searching look for the hidden, like you're playing with them and hiding toys. They will try to reach out for that. 2, 3, 5 years, then we can start actually recording the vision in different ways, which yeah. Okay. So infants from birth, this is a vision chart which is there everywhere. In infants, toddlers, preschool, and school-going children, how we see the vision. This, what I'm seeing is a preferential looking, a part type of very easy preferential looking, in which you don't need any special instruments or gadgets. You have to only see whether the child resists occlusion of any eye. If the child doesn't resist occlusion of either eye, it means the vision is good and equal in both the eyes. But supposing the child resists the occlusion of any eye, it means that the eye under the occlusion is a better eye, is a seeing eye, and the open eye is got a problem in the vision. Another test which is very easy is 100 or the 1,000 sweet test, in which you get the cake decorations that you get in the shops, in the departmental stores, the round balls, the sweet balls, and you have to put it in the palm and ask the child to pick up. So what we do is pick up the sweet balls and first put it in the mouth of the child. So now the child knows that there is something in the hand which he likes and he needs to take it. So they pick up that, and this is a very good test. And the child picks up even very fine cake decoration, and this corresponds to around 624 vision. And in the newborns and the infancy, there's always optokinetic drum, but these are all you need instrumentation for these. Visual acuity in infants and the pre-verbal.
What age children will respond to the sweet test?
Or anytime after they start having their grip, the pickup, no, from 6, 7 months also they start doing it.
Okay. Okay, thank you.
Excuse me, ma'am.
Yes.
Ma'am, sometimes parents come with their newborns, like, maybe 2 to 3 weeks old, and they're like, we doubt that the child cannot see. So, in these, 1 month type of babies, so what is the
Yeah. So how we see whether a 1 month child has got vision? In the basic vision that the child at this stage has is only around 8 inches or 10 inches. It's not, they don't have a distance vision, good distance vision. So here we do a blink test or a bright light test. So if the child has in a dark room and you switch on the light and they have a blink response, or you get a toy or some, just your hand also, and suddenly put it in front of the child's eye, and they have a reflex, blink reflex, that shows
Something
the
like
child.
Chinese,
Yeah,
Chinese.
yeah. So that means that they have some response. And 2 to 3 weeks is a too early time to say whether the child actually has any problem in the vision or not. You can do other tests. You can do your refraction, fundus, congenital anomalies. So all those things you can see to physical checkup you can do to see whether the child has any other anomaly which can be suggestive of a problem in the eye. Any birth history, all those things can give you just a suggestive indication whether they can be a problem or not. But directly 2 to 3 months, 2 to 3 weeks is too early, I think, because the child does not fixate that soon.
And so for such kind of babies, ma'am, let's say we complete a physical examination. So how soon do we ask them to follow up, that this would be the
Yeah,
ideal time when we can
yeah.
really tell you something?
So 2 months should be there, and we only have to assure the parents that this is too early and everything else looks normal, and there is no risk factor that we see for us to be concerned about. But if they are, we can see every month. 1 month, but by 2 months, the child should definitely start making an eye contact with the mother. And stranger anxiety and social smile should develop between 2 to 3 months, or at least 3 months. Then we have kids
Right.
with delayed visual maturation. In them, by 2 to 3 months, the vision does not develop, but still we wait for them to label delay. We call them delayed visual maturation. We wait till 6 months. So there are cases in which even at 6 months they suddenly respond and become normal. They catch up, especially in the preterm babies. They catch up growth is very good. So 6 months, before 6 months, we don't label them and get them investigated until and unless the parents are really anxious. In those cases, then we ask for a VP.
Right, ma'am. Yeah. Thank you, ma'am.
And
And that
VP
would be
also now,
flash VP, ma'am.
yeah, this babies will be able to do only a flash VP. And VP again, no, it has to be done from a reliable place, because I have had some cases in which they were reported no, absent VP, absent response. But the child was absolutely normal. The child was in an orphanage and was going for an adoption. So they wanted to get the whole thing tested, and they came to me for that. And the patient was having a good response, but somewhere they had a doubt. So we asked for a VP, and the VP showed a flat VP, but the child was absolutely normal. And when we saw again 1 month back, everything was normal. So your VP also has to be done from a reliable place, right? So visual acuity, again, this is a very big chapter by itself. So in any way, you can check the visual acuity. Supposing we don't have such big, fancy vision testing charts, it becomes at times difficult for us to have all these kind of charts. So these are there till 2 years or 3 years. So they are not very significant until and unless probably you're in an institute or doing a research thing to document whether the vision is 624 or 618. If the child is amblyopic, we have other signs to know whether the child is amblyopic or not, and they can be put on treatment and follow up 6 months also. When the child becomes around 3 years, they will be able to tell us, and we have enough time to recover from their amblyopia. So if you have any of these charts, it is very good. But if you do not have, you don't need to acquire them. You can do even without them. Okay, then you have K's and Sheridan Gardens and the Leah charts. So these are in the after the
Ma'am, I have one question.
yeah.
Okay, two actually. Till what age can we use the CSM method of that central steady maintained?
Yeah, that
That
we goes till you're not having any recordable vision, I think. No, because
okay,
at least till 1.5 years. See, it again depends on how active and a cooperative child is. Sometimes even at 2 years, we have to write CSM. If the
okay,
child is not cooperating, but he's able to follow your things, then you can write. But around 1 year, I think after 1 year, you have to start documenting other ways.
okay, ma'am. Ma'am, in this table that you're showing, which tests do you think, as general ophthalmologists, we should be using more commonly, or just to,
See,
I
in
mean,
the
get those?
first one, I myself don't have anything except this.
Okay,
I don't, and HOTV are there, but these I don't have any of these. None of them we have. Neither at my bigger place institute nor at my own setup. Until now, in this last 15, 17 years, I haven't felt the need of it.
okay, thank you.
Leah symbol, it
Yeah.
is mostly there in all the digital
Yes. But you
vision
need
chart.
to have a close one with you.
Yeah, the Madhu
Yes.
instruments, they have a very cheap 500 rupees
Yes. I have this
chart.
one, but I have
Uh,
this one, but I have never used it.
yeah, that is it.
Yeah. Okay.
Okay.
Now we go to the ocular movements. Huh. Very confusing, I think. Everyone knows the rectus, the lateral rectus and the medial rectus. So here, there's a very easy way which I remembered how to know whether with inferior oblique and the superior oblique, how they act. See, if you go to this picture, that forms a O. You only have to remember that the center ones, the upper one goes to the inferior and the lower one goes to the superior. The rest all you will automatically remember. So these are primary actions are there. I just want to know whether everyone is aware of the actions of the extraocular muscles, because many things depend only on this.
Yes, ma'am.
Yes, yes.
Okay, then I don't have to go into this. This is under action and over
How I
action.
remembered, 1 minute, how I
Yeah.
remembered that innervation chart is LR6, SO4, rest
Yeah,
are
that
3.
is an innervation. That we all know. But
Yeah, but the muscle movement.
yeah.
Yeah. Okay.
Yeah. So now I think one of you were asking for the under and over corrections. So here, this is the primary position. This is where how the inferior oblique acts. This is a right inferior oblique in adduction elevation. So this is in primary position also going a little up. So this is +1 inferior oblique overaction. This is nearly +3 inferior oblique overaction. This is a right eye inferior oblique. This is a left eye inferior oblique. So if you see, I have made a schematic diagram for the inferior oblique only. It is just going across the horizontal, it is +1. And if it goes like this, it is +4. In between, we divide it as +2 and +3. This is for inferior oblique overaction in adduction. Okay, now when we talk about under action. So in under action, this is an example of a lateral rectus under action. So full abduction, -1 is just, we are hardly able to make out the under action. -2, okay. So -4 is touching the midline. So -4 to -1, in between we divide it is -1, 2 and 3. -4 is, it is not crossing the midline. Look for compensatory head postures. The face turn is for horizontal deviations, like we have it here. This is face turn to the left, face turn to the right. Chin elevation is for the vertical deviation. This is the chin elevation and the chin depression. And this is the head tilt to one side of the shoulder, right shoulder or the left shoulder. We have done all the preliminary examinations. And now for the motor tests. We always forget the Buckner test. The Buckner test is, we see with a distant direct ophthalmoscope for the red reflex, which should be equal in both the eyes. If there is a patient with esotropia, there will be a difference in the reflex, the intensity of the reflex. There are other ways in which, other reasons also in which you can get an abnormal Bruckner's reflex if there is a leukocoria or there is another ocular problem. But in this case, in this talk, we are only discussing about a deviation, ocular deviation, which also can be picked up by a Buckner test. You can see from camera photos in which you get the red spot. Sometimes you get in one eye, sometimes you don't get in one eye. So if you closely look, probably they may be having some small amount of squint. In this Hirschberg's corneal reflex test, 1 mm shift is nearly equal to the 7 degree or 15 prisms of deviation. So we see the 0 is at the what we spoke about in the nasal to the center of the pupil. If we take this as 0 and this as 45 at the limbus. So at the pupillary border, it is 15, and midway between pupillary border and the limbus is 30, 25 to 30. So how do we measure the deviation? Here we'll see about the cover test, cover uncover test, alternate cover test, and the prism cover test. Look at the forias here. See, can you make out the gradual deviation of the left eye under the cover? Could you appreciate the foria here? Cover, uncover test. This is cover and uncover it will see it's taking a movement.
Yes, ma'am.
Yes, yes.
See, this is cover, uncover test for forias. Okay. Now, this is an alternate cover test, which takes both the eyes. I did not get a patient for tropia cover test. I had it in archive, I couldn't upload it here. So in this patient, I'm showing you how we are doing the prism cover test. Okay. If you see, I'll go back to the first one. This is an exotropia. Okay. From outside to inside, the eye is coming. Now, when we neutralize it with the prism, I wanted to show how it goes to, it's gone to ESO. Is it appreciable?
Yes, ma'am.
Okay. So the endpoint of a
Yes, it is.
neutralization is when the deviation either becomes ortho or depending upon the surgeon, whether they take it at a little over ortho. I take it a little over ortho, especially towards the ESO side.
Ma'am, when we are doing the prism cover test, which one do you recommend? Whether we use a prism bar or
No,
a
no,
loose prism?
always loose prisms.
Why is that, ma'am?
Yeah, see, you can do because what I feel is in the prism bar, first of all, if you are to be sure that it is made, whether it is of glass or of acrylic. And other thing is that the width of the prism bar is very small.
Okay.
Each prism is very small. I somehow feel it does not cover the proper eye. And the other thing is till your 35, 40 prisms, 40, 45 prism, it is okay. When you want to go beyond 40 prisms, 45 prisms, you want to break the prisms into both the eyes.
Yes, ma'am.
So in that case, the loose prisms. But I still say the people who are not regular squint practitioners, instead of not having anything, it is better to have a prism bar. And with prism bar, you can also do a very good convergence exercise. So it is always nice to have a prism bar. So when we
Ma'am,
go
how
to
do we, sorry,
yeah
how
yeah
do
then-
we, how do we use the prisms when there is a vertical and a horizontal component? How do we place the prisms?
yeah, you have to place in both in two different eyes. You don't place them together, stack it in the same prism in the same eye. One
Okay.
side horizontal and one side prism. So you at times need another person assistant, or even you can get a patient's attendant to hold the prism when you're testing for vertical and the horizontal deviation together.
So in this prism test, we don't need a source of light to look at the
Yeah, I'm coming
reflection.
to that. See, now if you go to the prism cover test here, there are many components in this. We have to take the measurement with the glasses and without the glasses, for distance and for near, and preferably in all the 9 gazes. It is only then that we get to know whether there is any pattern deviation. Though more common, the pattern deviation that we talk about are the A and the V pattern. The A pattern is when the deviation between the up gaze and down gaze is more than 10. We take it as a significant in A, and if it is more than 15, we take it significant for V. So but even in the lateral gazes we should do, because exotropias can get lateral incompetence, in which case we need to see the deviation in lateral gazes, both right and the left gaze. And you had asked some question about prism bar cover test measurements.
Ma'am, do we need a source of light
Target.
Yes.
Yeah. So the purpose of prism cover is to get the maximum amount of deviation that you can elicit. So when we measure for an exo deviation, we take a spotlight, a diffuse target. We don't need an accommodative target, because in an accommodative target, they are able to accommodate and reduce the deviation. Whereas in esotropia, we want the maximum deviation, so we get an accommodative target and ask the patient to focus at the accommodative target. to take out the maximum deviation.
Okay, ma'am.
So for exo deviation, mostly we go for a diffuse target, and for ESO deviation, we go for an accommodative target.
It doesn't have to be a light source. It can be any target.
It can be any target, yeah.
Okay, okay, ma'am.
But light source it
How
only
far
becomes
should the
if your torch is the present day torches are really very bad, the LED torches. So I put them a little distance only. See, the purpose is only to make the patient get a source of fixation, not random. If you tell them ki look far away at a tree or something, they might not find any focus, so they'll just have a searching moment. In that, it becomes a little difficult to do the measurement. So if you give them a target which is not an accommodative or a fine focus target, that is good enough. Anything is good. You can even ask them to look at any object. Need not be a light source.
how far off? How far off?
For an exotropia, it should be at the Snellen's distance. It can be even further distance. It can be even very distant. If you're in the chamber, you can ask them to look outside your chamber also. As far as possible, if it is an exo. For an ESO, it should be at the reading distance. You have to measure in all distance near all the gazes. But the maximum deviation that you important in both the cases is for ESO in the near and for the exo in distance.
And we should get somebody to, like if we are doing the prism cover test, both our hands are engaged, so somebody else should be giving a target,
You can
maybe for a ESO.
yeah, no, you can ask the patient to hold the reading material. They also can hold. अगर नहीं है तो
Okay.
you can ask someone to. You will need someone to hold that.
कहाँ से होल्ड करेगा? मुझे वो पोजीशन कभी नहीं समझ आती. मतलब
See, in my
पेशेंट
video, I
अपने
just
आई
showed
लेवल
you
पे होल्ड करेगा. पेशेंट अपने आई लेवल पे होल्ड करेगा.
at the arm's
अटेंडेंट उसके आई
distance.
लेवल पे.
Arm's distance, जहाँ से उसको पढ़ पा रहा है, around 30 centimeters, 50 centimeters. जो reading distance है 30 centimeters पे तो पढ़ लेगा.
नहीं, हम
नहीं,
कहाँ पे
what she
खड़े
means
हैं?
to
मतलब
ask is, yeah, when he is reading, his eye is looking down, na? He's
No,
supposed
you have to make him look up. You have to get the reading
yeah,
material
that's
up.
what she's saying. Yeah,
Yeah, you have to get the reading material up. नहीं तो वो डाउन गेज में हो
नहीं,
जाएगा
रीडिंग
ना.
मटेरियल आप तो हो गया.
Primary
नहीं,
gaze में. Primary gaze
कम.
में.
Yeah, Arpana, you have to get it in primary. Your voice is
आप ही
breaking.
खड़े हो, मुझे अपना और उसका नहीं समझ में आता.
Your voice is breaking.
मुझे अपना, एक मिनट, मुझे अभी ठीक है.
हाँ
It's
हाँ.
fine now.
Yeah.
हाँ. अभी like it is between me and the patient, the target.
Yes.
तो मतलब हमें बहुत दूर खड़े होना होगा उससे.
आप दूर खड़े होगे तो
30 से दूर
मेजरमेंट,
खड़े होना होगा.
आप मेजरमेंट कैसे लोगे दूर खड़े होगे तो?
हाँ, तो यही तो पूछ रही हूँ, फिर मैं कैसे खड़ी होंगी?
आप
मैं
साइड में खड़े
रहूंगी.
होंगे. आप साइड में, मैं भी साइड में खड़ी हूँ ना अभी.
नहीं, तो साइड में खड़े हो तो आपको सामने से नहीं देखना होता. मतलब आपका साइड में तो पैरेलल
डिविएशन
हो जाएगा.
नो, पैरेलल थोड़ी, हम तो डिविएशन मूवमेंट चेक कर रहे हैं ना. हम पैरेलल से हम ऑब्जर्व थोड़ी कर रहे हैं, हम तो मूवमेंट चेक कर रहे हैं.
So we are not checking the Hirschbergs. We are just seeing the eye movement.
Yeah.
Okay. That gets confusing ना. हम normally case सोचते हैं Hirschbergs में हम check करेंगे. Here we are checking the eye movement and not the.
Yes.
So we can stand on one side and
Yeah.
give the target.
Yeah.
Okay,
We always do on the side, from the side. Okay. These days, what I also use as a target is you give the child ask what cartoon the child, what's the favorite cartoon, and play that cartoon. And that is a very good target for the child to see and for you to measure. Okay. So we need to see a distance and near base to find out whether it's a basic, excess, or insufficiency type, especially in an exotropia, with and without glasses, to check out for the accommodative element. In all the gazes, 9 gaze of vision, you have to check for the measurement, and you have to take the measurement in all the 9 gazes. Up gaze we consider 25 degrees and the down gaze 35 degrees for the patterns. And to check for the primary and secondary deviation, subjective and objective method of measurement, like what we do PCT, the subjective method. Now we have computerized methods also for taking the measurements. So they have some way of kind of clicking the photo which analyzes, and I've just read it on the net. I've not seen it. And okay, once you are sure that your measurements are okay, then we proceed next. But supposing you are getting a discrepancy in distance and near, and you're not sure whether it is correct or not, especially whether it's a pseudo divergence type or a convergence excessive type one. So what we have to do is we have to put a patch test. So any one eye we patch and make the child patient sit for 30 to 40 minutes. And then once we remove the patch, we should not allow the child to have a binocular fusion. As you're taking out the patch, you should cover the other eye, and before the fusion develops, you have to take the measurements. This is in a fully dissociated deviation measurements you have to take, and then that will be your correct measurement and if that matches with your initial measurements, then fine. Otherwise, this will be your final measurements. Is this part one clear? Hello?
Hanji, in the sense ki we are making him uniocular first.
Yes. You have to break the
And
fusion. You have to break the fusion. The purpose is to break the fusion.
and then make him play or whatever for about 40 minutes.
Play, nahi, just he can relax. एक आंख बंद करके you have to break the fusion. Give time for the fusion to break. And before
तो
it
ओपीडी में बच्चे
refuses,
को तो छोड़ देंगे, जो करना है कर तू घूम.
हाँ हाँ, पर बच्चे को ऐसा भी नहीं छोड़ना, वो सबसे पहले पत्ती उतार के फेंकेगा.
Oh, we have to explain it to parents.
Yeah.
So then we cover the
Any
cover
eye,
the
doesn't matter. Any eye.
seeing eye and then remove the patch.
Yes.
So we
Yes.
cover the seeing eye,
Yes.
unpatched eye, and
Yes.
remove the cover and see where the eye position is.
No. After that, you have to do a very rapid measurement of the squint.
Cover and cover.
Yes.
वीडियो बना लो, बेटर है.
बना देंगे, 4 डाल दूंगी आपको.
नहीं आपको नहीं कह रही हूँ मैं. जब एग्जामिनेशन हम uncover कर रहे हैं, it's better to make a video at the same time what you are recording. That's my suggestion.
No. If you make a video, how will you measure?
How will you measure? एकदम इतना rapidly कैसे measure हो जाता? हो जाता है?
नहीं, वो you have to, it has to be fast. Before the patient refuses, you have to do the measurement.
Okay.
नहीं, ये प्रिज्म के साथ करना है या हवा के साथ करना है?
Prisms.
अच्छा, ठीक.
Ma'am, for
doesn't
cardinal, sorry.
Yeah.
Hey, go ahead, doctor.
Yeah, ma'am, for cardinal positions, in that it's not distance, it's not for distance and near, it's just the cardinal positions, है ना? उसमें तो कोई distance near का नहीं होगा measurement.
You see, again, what I say is exotropia. See, if you have primary gaze, you're sure that it is a basic type, that the distance and near are equal. Then it doesn't matter.
Yes, ma'am.
But supposing you are having a discrepancy, in that case, you have to see where the maximum deviation is, if it is for distance or the near. Mostly in exo, it will be for distance. But still, you can have the convergence insufficiency types in which you can occasionally get even for near higher. So in that way, wherever you're getting the whole purpose is to get the maximum deviation wherever it is, because our plan of surgery will depend on the maximum deviation. So even in the other positions of gaze, I'm not talking about the upper gazes, mostly in the exotropias, in the outer gazes, in the right and the left gaze, you get what is called as lateral incomitance. There can be a difference of at least 5 prisms in primary gaze and right and left gaze. In that case, we plan to do a lateral rectus, bilateral rectus recession instead of doing an R&R. Or we recess more of the lateral rectus and do less of a medial rectus. So in the side gaze, it is important. But whether you're doing for near or distance, wherever you are getting the maximum deviation.
Right.
So the pattern deviation, as I told you, it's for the A and V is a very common pattern deviation, but you get X pattern, lambda pattern, and there are many patterns because of which we have to take the measurements in all the gazes. We just can't take in the primary gaze and up gaze and down gaze and decide for the pattern. Now we come to the sensory examination. So again, there are many theoretical sensory examinations like simultaneous macular perception, fusion, stereopsis, Worth-Fodor test, Begolini straightest glasses, the Maddox rod. Of these, the routinely that I do is the fusion, stereopsis, Worth-Fodor test. Begolini's striated test and the Maddox rod test is for 4 years again. And in the paralytic squint, we do again for the tropias. But routinely, I personally do not practice it. So in the stereopsis, definitely is very important that we have the stereopsis measurements, because especially in the accommodative esotropias, in which stereopsis kind of gives you end point of stopping the treatment. If supposing the child with the due course of treatment has become ortho and you want to slowly wear off the accommodative glasses and the stereopsis is good, once a stereopsis is developed, it is very rare that the child would again go into ESO. You can slowly, gradually wear that off. So we go to these are all the how we routinely should examine every patient of squint. Now we come to the concomitant squint or a non-paralytic squint. This is the type of manifest squint in which the amount of deviation in the squinting eye remains same in all directions of gaze and there is no associated limitation of any ocular movement. So there are, we are mainly talking about the horizontal deviation, the esotropias and the exotropia. Esotropias are, the common ones are the congenital or the infantile esotropia, the accommodative, acquired non-accommodative esotropia, the cyclic esotropia, sensory esotropia, and there are some rare other forms of esotropias too. The features of a congenital or infantile esotropia are, first of all, there is no neurological problem. There is no significant hyperopia. It could be less than 3.5, but it can be around 6, 7 and still be a infantile non-accommodative esotropia. Angle mostly are large. They can go to anywhere from 40 to 70 prisms also. They can go into cross fixations. They may or may not be associated with nystagmus. The ideal time for management is before 2 years of age, because by then they can develop a stereopsis. But this should not be your criteria for management for the treatment. The criteria first should be to manage the amblyopia. How do we know is if supposing one eye is squinting, it means definitely that that eye has got amblyopia. So we have to first convert a one-sided squint to an alternating squint. If it is an RET or a LET, try to convert it into an alternate ET. And in cases of cross fixation like this child, what happens is that the medial rectus becomes very tight. So when we open these cases for operating, the measurements of a tight medial rectus sometimes does not give the effect that we are expecting. So in this case, we are doing the patching so that the child develops the ocular movements of both the lateral and the medial. And once there are free ocular movements and the child has gone into an alternating ET, that's at best the ideal time to operate. Any questions on this?
Ma'am, for like you said, tight medial rectus. So, how is tight medial rectus diagnosed, ma'am? Is it some kind of force duction test or something that we do?
No, we can't do in these kids. If we do, we have
Right,
to
ma'am.
do it in under GA. And even in
Right,
under
ma'am.
GA, when we are doing, it has to be within the initial 5 to 10 minutes of inducing GA before the child goes into a deep stage 3 or what that GA is called. We have to do in the initial stages. But even if it is, we don't need to check because we don't expect it to be a restrictive type of strabismus. It is only that the cross fixation, and it takes time for it to become a tight muscle. So when you see, if you put the child immediately on alternate patching, the movement comes back very fast.
So that means, ma'am, first, if we encounter this kind of an infantile squint, the first thing that we should do for cross fixation is patching,
Yeah.
right? Then once, right, ma'am, then we proceed for surgery when it becomes like alternating kind of squint.
Yeah, but supposing it is not happening, in these cases, we would anyway do a bilateral bimedial recessions. Okay, now these
Right,
cases,
ma'am.
the best part of these patients are they have good vision in both the eyes because
Right,
of
ma'am.
cross fixating and seeing from both the eyes. So you can give a trial of 3 months or so if the child is able to do it, if the parents are able to do it. Otherwise, go ahead and take up your decision to operate. It gives the parents also some time to think and accept your treatment. As soon as the child comes and you tell operate karna padega, they don't accept it very easily. So
Right,
once
ma'am.
you tell them that this is a condition, we'll wait for it, and then as soon as it comes, and we always also have to tell once the child has got one side squint like a RET or an LET, and you put the child on patching, they'll come back with a complaint saying अभी तक तो एक ही आंख में था आपके ट्रीटमेंट के बाद दोनों आंख में स्क्विंट आ गया. So you have to tell them initially that that is your end point. When the squint comes in both the eyes, that is a desirable result, and not to worry, get anxious about that. Okay.
Right, ma'am. And in these cases, ma'am, how much is the duration of patching that you advise normally? Is it based on the angle of esotropia?
No, it's never based on the angle of esotropia. See, initially, the protocol was depending upon the age, and minimum being 3:1. Whole day 3 days and 1 day open. Then whole day 3 days, that's called 3:1. So till the age of
Right,
three
ma'am.
years, we do 3:1. And after that, 4:1, 5:1, 6:1 till the age of 6 years. But now what the
Right, ma'am.
protocol is, you do a part-time patching, 6 hours of patching. The patching also depends on how dense the amblyopia is and what the age of the child is. Supposing the child has come to you at the age of 6 years with a dense amblyopia and has never taken a treatment, these kids do very well with a dense patching, with a full 6:1 patching. The recovery is very fast. Same child at the age of 6 years comes with a 6:24 vision. They will not uh, have a very good result with the 6:1 patching, and they will rather not do it. So for them, you have to do a part-time patching with some enforced amblyopia exercise. You give them some fine work to do with that lazy eye so that they develop their strength in that eye and their acuity improves. So these cases, you have to see how dense it is, and when your treatment is starting, how much time you have left. If the child is coming at the 3 years of age, you have a lot of time left. But if the child is coming at the 7 years of age, you don't have much time left. So your everything has to be customized based on the basic principle.
Right, ma'am.
Okay, now we go to the accommodative esotropia. So accommodative esotropia develops usually between the 6 months to 7 years of age, but the main time is around 2.5 years of age. Intermittent at onset, then become gradually constant at over time. May be initiated by trauma or illness. Most of the time it doesn't happen. And with the present days when most of the kids are on screen, phones and mobiles and computers, this is what is the main precipitating thing of accommodative esotropia. They again can be associated with amblyopia. Occasionally there may be complaints of diplopia, but slowly that also, because of the development of a suppression scotoma, that also goes off. There may be a hereditary basis because a hypermetropia can be a hereditary running in the families. So The accommodative in resotropia can be refractive, non-refractive, and partially accommodative. The common thing and most important thing is the AC by A ratio. So how do we develop the AC by A ratio? There are two methods. One is the gradient method and one is the heterophoria method. In this, in which we do the gradient method, the easiest test is you look for a deviation at distance and near. First, the child wears a full correction. After wearing the full correction is the cycloplegic correction. The child wears a full correction and then you do the deviation for distance and check for a deviation at near. Then if there is a deviation at near, add +3 in both the eyes and recheck the deviation. So the formula here is A minus B by 3. So add distance at near and then at near with +3 divided by 3. So if it is more than 6, it means that there is a high ACY ratio in which we give the bifocal correction.
Excuse me, Dr. Sapna. When he's wearing that +3 convex, he's wearing it over his refractive correction?
Yes, yes.
Okay, okay, thank you.
Okay, when you give the bifocals, again here you have to remember a couple of things. Most of the time when you go, you give the prescription and they go to the optical people, they say that the bifocals come in glass, not in plastic. So you have to check that, ask the parents also to check if the person can make the bifocal in plastic. Try not to take in glass. They are difficult, but they can be made. And the bifocal segment, when we see in the elderly and give bifocal, the lower segment is 30% and the upper segment is 70%. But here it is reverse. The lower segment will be 60% or even 70%, and the upper segment will be 30 or 40%. And we give an executive bifocal. There have been people who have tried to give progressive multifocal, but I feel that that is not a very correct treatment. It's only because of the parents' comfort that we give I don't give, that people give a progressive or a multifocal, that bahar se nahi dikhna chahiye that child is wearing some different type of glasses. Okay, anything in this accommodative esotropia? So how do we wear this off? Supposing we have done a cycloplegic retraction and it's a normal accommodative ratio, esotropia with normal AC by A ratio in which we have only given plus glasses. So by 10 to 12 years of age, we remove the glasses. So by 8 years of age, you start half a number every 6 months, you can reduce and keep calling the child to see whether the squint is being maintained or not. Supposing the squint develops again, then you will have to go back to the initial correction and continue, keep repeating this as an in between and see when the child is able to accept your reducing of the power. Okay. Anything here?
How much power to reduce in every?
I have half a diopter. I do every 6
half that.
months.
Okay.
Yeah, and also you have to see whether the child, at times what happens is the vision falls when you're giving full correction. Supposing the child is wearing 6, but with 3 diopters, he gets a 6/9 vision. But with 6 diopters, though he becomes orthophoric, the vision goes to 6/18. You cannot compromise on the vision to and correct an orthophoria by glasses. It means it could be a partially accommodative squint in which the vision we have to also see, because in the we are correcting the squint, but we are creating an amblyopia.
So we have to like just see ki 6/9 tak whatever correction
No,
is
you
taking by
first
fogging.
see, yeah.
Like we do by fogging
See,
and we
initially
make
we
him
are giving
comfortable.
full. Initially we are giving him full correction. अगर under atropine you have done in 7 का retinoscopy आया है, you're giving around 6 or 5.5. Okay,
Yes.
but fogging, if you're giving, he might be taking around 4.
Yes.
But initially you give the full correction. It is when you are starting reducing, then you start monitoring the vision also. See,
Okay.
supposing the child accommodative esotropia is coming at around 2 years of age, 2 or 3 years of age. That time that we are not emphasizing on the vision. We are right now seeing here on the child going into an orthophoria. Once a child has taken, accepted the glasses, 6 months, 3 months, 6 months follow-up, then the child starts recording the vision. You can record the vision then and then follow up.
Okay. Okay. Thank you.
So now we are going to exotropia.
Let me just interrupt you a bit.
Yeah.
What is the role of AC by A ratio here?
Okay. So we give bifocals if there's a high AC by A ratio.
Okay. That is the indication of giving bifocals.
Yeah. It means that there is more of
there is a weakness of accommodation or convergence.
No, excess of accommodation. For that amount of convergence is excess of accommodation.
Correct. So we need to relax that.
Yeah.
Oh.
And how much power do we give for the bifocal?
Okay.
So we give around 2 diopters, 1.5 2 diopters of near vision add.
Okay.
So exotropia classification. We have the intermittent exotropia. This is a Kushner's classification. Intermittent exotropia, the basic pseudo divergence excess, true divergence excess, and the increased proximal convergence. Then we have the convergence insufficiency, and the more very common is the sensory exotropia. In this part, I have already told in the intermittent exotropia, the basic is when the distance are near and in all directions of the gaze, the measurement is the same. In the pseudo divergence excess, in which we do the patch test and then the distance and the near become same. That is why it is a pseudo divergence excess. Before patching, the divergent for the distance, the divergence was more, but for the near, it was less. Then the true divergence excess is, even in spite of the patching, it remains different for distance and near. And in the increased proximal convergence exotropia is, the exotropia is mainly because of the convergence factors. Earlier it is a divergence factor and here it is a convergence factor. Then we have the convergence insufficiency and the sensory exotropia. So the treatment options for
Any issues now?
Yeah, is my screen coming? No.
Yes, we can see.
But I can't see my screen.
We can see, ma'am. It's visible.
I can't see my screen.
मिनिमाइज तो नहीं हो गया?
नहीं यार, कुछ पॉपअप्स आए थे तो your screen. Okay. But how does it break?
You want to restart, madam?
Restart कैसे करूँगी? Stop sharing.
You want to leave and join again?
Okay. Wait.
We will be here. Yes.
Share screen. Oh. Okay. Yeah. Okay, so the treatment for intermittent exotropias. Again, it depends on the time when the child presents to us. Supposing the child has come at 3 years of age. So exotropia, as esotropia, we treat around 2 years of age. Exotropia, we treat around 4 to 5 years of age. Because we don't want the child to get overcorrected and to go into esotropia. Because in that case, the child will develop amblyopia and then we will have to start the treatment for the amblyopia, patching and everything. So the cutoff age for exotropia treatment, especially the intermittent, constant one we treat whenever the child comes for the correction. For the intermittent, we do after 4 years of age, 4 or 5 years of age. And again, you have to see the magnitude of deviation and how often it is. So it is, if it is more than 30 to 40% of the waking hours, and the parents are keen on getting it corrected, then we do it earlier. Otherwise, we do it after 4 to 5 years of age. Till then, what do we do? The intermittent exotropia presenting at the early age, we do an alternate day, alternate eye patching. See, the rationale for this treatment is not very clear. It is to dissociate the images, it is said, but the results are very positive. We get very good results on alternate day, alternate eye patchings for intermittent exotropia at a younger age group. If the child is already having some amount of refractive error, then you can give an over minus. Over minus induces accommodation, which helps in controlling the intermittent exotropia. Over minus is around -1 extra, -1 to -1.5. You can also give prism corrections. Occlusion therapy I've already told. And in vision therapy, you have a lot of types of convergence exercises, anti-suppression and fusional exercises. Like you have the Brock strings, you have the prism bars, you have the cat cards and pen push-up. There are many exercises till the time we are waiting for any surgical intervention. So you have to be very clear to the patient that we are controlling the deviation, we are not curing the deviation, and the cure is surgery. Okay. So
Ma'am, does every sorry.
Yeah, Polo.
Ma'am, does every intermittent squint require surgery later on?
See, there are a couple of factors when we talk about the intermittent squint. First, how frequent it is and what angle of deviation it is. Supposing the angle of deviation is around 15 to 20 prisms, that can easily be overcome and maintained by your convergence exercise. But supposing it is 35, 40 prisms, see the effort the child has to make always to overcome that much amount of deviation and to remain orthophoric. He will always complain of headache and running of letters and difficulty, poor performance in the schools. So these are all symptomatic and individual based. Supposing there is a good tone, good diet, the child does not fall frequently sick, everything else is well maintained, there is no any symptoms associated with this squint, you can maintain it as long as you want, but that will be a control. Anytime the child, the patient falls sick or is having very tired or very sleepy, that it show the squint manifests, and in that case, that's what I'm telling. This the control patient can go as long as they want, but the final cure will be surgery. I have not seen many patients who initially with the good control have maintained so or become totally orthophoric. If you induce, you will still get an exophoria which is going into tropia. It is only that we
Yeah.
don't induce or they don't come back for that.
That is what I wanted to ask. Many times the parents will come and say कि कभी कभी squint होता है. When we see they are totally orthophoric, how do we check? What do we do in that condition?
One thing is you can do the patch test and do. If there is having any hidden thing, it will come out. You can do a patch test. Second, you ask them whenever they have find a deviation, they can give they can take a pic, they can do a record, or you can just scan their old pics and see if there's in any time there has been a deviation which is visible. Supposing in all the ways that you have checked and there is no deviation seen, you anyway are not going to do any treatment. See, our cutoff for the treatment also is 30 to 40% of the waking hours. Supposing there is such a rare instance of he getting squint and you operating on that squint, then the child very easily can go. It means that he has got such a good convergence tone that he is able to control it. So in that case, when you operate, you will not be giving a good result. So we only will observe anyway for that.
Okay. Okay. Thank you.
So what are the general principles of the squint surgery? Medial rectus recession is always gives a higher correction than a lateral rectus. So 1 mm of recession or resection of a medial rectus corrects around 3 prism diopters of deviation, and for lateral rectus it is 2. Medial rectus, our maximum is 5.5. We very rarely go to 6 also. But lateral rectus, we go even till 8 and 9. There are different nomograms every book and every surgeon follows. We also follow what we were given or taught in Arvind. And these are the various nomograms given in various books. So it is said you have to make your own nomogram. But in private practice, you have to follow some nomograms because the patient won't give you that much of time. You can't make mistakes. So the ideal what we see here, supposing it is an, I'll go to this one, 35 prisms of exotropia. You can comfortably do a bilateral 7.5 millimeters of recession. Recession is better, but supposing it is already a recessed eye, you can go for a medial rectus resection. My personal is the recession, bilateral lateral rectus recession gives a good result, but it is not a maintained result. The recurrence rates are very high. So you have to top it up with a medial rectus resection, even if you're doing a small amount. Even if 4 mm you're doing, there has to be topped up for a long-term good result. So I think Dr. Madhurama, you were asking for the calculations. So what my calculation is for 35 prisms of any deviation, whether it is ESO or EXO, it is 7 and 4. 7 of lateral rectus and 4 of medial rectus. So this is how I remember. After 35, if it is 40, depending on whether it is ESO or an EXO, I increase 1 mm either in the medial rectus or in the lateral rectus.
Okay, ma'am. Ma'am, I had one question. So, after correction of squint, what are the indicators that the patient may have diplopia? I mean, pre-operative.
See, exotropia, nearly 100% will have diplopia. So,
Okay.
yeah, so and that diplopia correction depends on the patient's ability to fuse the images. So it
Okay.
can be for 5 minutes, it can be for 15 minutes, 15 days, 2 months. I have had patients who have had some mild amount of diplopia even for 2 months, but it gradually goes off. And till that time, if it is there, if the patient is having a residual exophoria, you can put them on convergence exercise. And if the patient is having an ESO, which is actually good, you just wait, it will come back. It will become normal.
Okay. Thank you.
Okay, so this I have actually taken from my old talk for my friends in Delhi, that this is how I need the documentation when you take opinion from me for a squint case. I needed all the 9 gazes, how the patient is looking. So this is for your documentation and for everything. Even if you want to take an opinion, it is better that you have in all the 9 cases. So
देते तो हम फिर 1-2 में ही है, रिकॉर्ड तो निकलता तो नहीं है वरना
9 गेज में तो कभी आज तक किसी ने नहीं दिया.
हाँ वही तो कहती हूँ, देते तो हम 2-4 में ही आएंगे, ये देख लो वो देख लो.
मैं तो वीडियो बना देती हूँ, ये है जी, कर दो क्या करना है. पेशेंट वापस नहीं आता.
Okay, so here we finish our concomitant squint. So the take home message here is you identify the squint, whether it is a pseudo or a true squint. Assess if you can manage it. Otherwise, refer it for a timely treatment. ESO deviation before 2 years, EXO at least minimum after 5 years. Till then, manage, do a complete refraction, put him on convergence exercise, or counsel them how the course is going to be there. The patient will remain with you. Now we go for the incomitant, which is again a very lengthy one. If you want me to continue, I can continue. Okay, shall I go fast on it? And
Yes,
see?
ma'am.
Okay.
Yes.
So the incomitant squint, we'll go, it is by definition, the deviation varies in different cases. The causes are neurogenic, myogenic, mechanical, and the differences between paralytic and non-paralytic. The comitant is I think the main important thing is the secondary deviation is more than the primary deviation. There is limitation of movement. The presenting complaints most of the time is diplopia, and there can be a head posture. Again, here there are many terms which are very confusing and which you need to know, because especially in oblique muscles, the agonist, antagonist, synergist, and yoke muscles. So because in oblique muscles, once the paralytic squint develops, there is a spread of comitants, which we need to know. In stage 1, there is an overaction of the ipsilateral synergist. So if you are seeing in a lateral rectus, if the lateral rectus is paralyzed, there will be overaction of the ipsilateral synergist, means the ipsilateral medial rectus. Then overaction of the direct antagonist, overaction of the yoke muscles, and underaction of its antagonist, underaction of the contralateral antagonist. This is the spread of comitants. This is very important when we are doing the Hess charting, because we don't know at what stage of diplopia the patient has come to us, and when the primary deviation to the presentation of the deviation, what is going on. For that, we need to know the spread of comitants. So these are the yoke muscles. And this again, I have taken if this is a superior rectus, this is the yoke muscle of the superior rectus. For this one, again, this is the yoke, these two are the yoke muscles. So we only need to know what the yoke muscles are in the paralytic squint. This again is the yoke muscles. The types of incomitant squint can be congenital and acquired. Both have the same neurogenic, can be congenital nerve palsies or an acquired nerve palsies. The myogenic is mostly acquired, which can be thyroid or the myasthenia. Mechanical in the acquired can be acquired Browns or related to trauma, in which there is an entrapment of the muscle. The complaints mostly are the diplopia, head posture, vertigo, or associated with other neurological or systemic conditions like headaches, vomitings, trauma related to the trauma. This is the compensatory head postures. The diplopia, I will cover a little bit. You have to take a detailed history of diplopia. It's a monocular diplopia or a binocular diplopia, onset of diplopia, whether there is a difference in the distance or near, or which gaze of vision is the diplopia most troublesome to the patient, whether there is any diurnal variation since the onset, and since the onset to the time of presentation, whether the diplopia has progressed, regressed, or remained same. Diplopia associated with trauma and any associated conditions like headache, vomitings, ataxia, to know whether there is any other neurological condition going on in the body. For any incomitant squint, we test for the abnormal head posture, cover test for the secondary and the primary deviation, diplopia charting, Hess charting, Worth-Podot, and the post-duction test and the post-generation test. The diplopia can be tested by the red filter test, the red and green filter diplopia charting, Worth-Podot test, Maddox rod, and the Begolini's classes. I will mention your main one is the red filter test. Every trial box has a red filter. A patient comes with you to you for a... Hello?
Oh, I'm sorry.
Yeah. So the red filter test, you take the red filter from the trial box and take the retinoscope, the vertical slit beam from the retinoscope, and put the red filter in front of any eye and ask the patient about the diplopia. It is a simple bedside test for diplopia. So you have to ask in all the gazes to see where the maximum separation is, whether it is horizontal, vertical, or a torsional diplopia, and whether it's a cross diplopia or an uncrossed diplopia. The proper charting can be done with a red-green filter, in which you put a red in front of the right eye and green in front of the left eye and do the charting. I'll tell you how the charting is recorded. Then you have the Hess charting, which quantifies where the deviation is maximum. The Hess and the Least chart, this is the list chart and this is the Hess chart, in which we get a chart like this. We have to first read the inner box, then read the outer box. The inner box in which there is an underaction of the muscle, and corresponding, like here there is an underaction of the right inferior oblique, and correspondingly you have to see the overaction of the other muscles. This is where the spread of committance comes, and you should know these obliques, how they spread, and where the overaction will come for the underaction of this muscle. Okay, I'll go fastly on the force duction test and the force generation test. Force duction test is done under topical anesthesia. The patient is asked to look at the direction of the limitation of movement. So supposing we take at the lateral rectus, if the lateral rectus is passive, we ask the patient to look in the abduction of that same eye, and then we hold the eye at the limbus with the forceps and move in that same direction of the abduction. If there is a further movement which is free, it means it is just a paralytic deviation. But if there's a restriction in the movement, it is not going in that same direction further than what the patient has already taken, it means that there's a restrictive movement. When we do the FDT for a recti muscle, never push the globe down. Rather, for the recti, it is better if you slightly proptose the globe and then do the movements. In the force generation test, what we do is we hold the muscle in the primary position with the forceps, similar to what we did in the force duction test, and then ask the patient to look in the direction of the limitation of the movement and feel for the tug. Supposing this again, we take the example of the lateral rectus and we hold it in the primary gaze and ask the patient to abduct the eye on the right side. If there is no tug or the feel resistance that you feel on that, it means that there is no tone or the movement in that patient. This is important in the recovery of the paralytic squint. If there is some generation of the movement in that muscle, there are a chances of spontaneous good recovery. But otherwise, the recovery prognosis is a little poor. This is done as it's given to check the strength of the affected muscle.
What instrument do we use?
Limbs forceps.
Okay.
So for any, also to check whether there's a torsional component in the deviation, we have already seen in the diplopia charting. Now we know that there is some not only horizontal deviation, there's a vertical deviation. So the fundus picture also shows us the torsional deviation. So the normally this is around 6 degrees from the center of the optic disc to the macula fovea. This is normally slightly inferiorly placed, which is 6 degrees. In torsion, it can go anywhere to grading of the intorsion and grading of the extorsions. So this shows only that there's a torsional, so oblique muscle involved. So there's a difference between the neurogenic and the myogenic, the paralytic squint. So this we mainly the duction in the force duction test and the force generation test we know. The many restrictive strabismus that we know are of the mechanical Duane's Brown syndrome, the Mobius syndrome, congenital fibrosis of the extraocular muscles, and the myopic strabismus fixes. I have not covered these in except mentioning it. Okay, so how do we do the diplopia charting? So red in front of the right and left in front of the green in front of the left. So here, the exo deviation will cause cross diplopia, the eso deviation will cause uncross diplopia. So here we see this is a lateral rectus underaction, paralysis, this first one. So lateral rectus is medial rectus overaction. So eye is in ESO. So if the eye is in ESO, the right eye is in ESO, you should be getting uncrossed diplopia. So here, this is the right eye, right side of the patient, and this is the left side of the patient. So right side, you're getting deviation, and the left side is all single vision. So diplopia charting is done wearing red and green glasses, and the dull image is mostly of the palisade muscle. Maximum separation is in the gaze of the action of the muscle, the cross diplopia and exotropia, and uncrossed diplopia and the esotropia. To differentiate between superior oblique and superior rectus mostly is the Parkes 3-step test. So first, let us consider here that there is a right hypertropia. So right hypertropia can be because of the paralysis of either the right under the depressors or the left elevators. Is it, are you able to follow?
Yes.
It's the
It's going to-
obliques which are working here, no?
No, see the right hypertropia, right side is up. So it can be because of the right side
Inferior oblique.
depressors underacting are paralytic, or the left side is hypo because uske elevators are underacting. So this is step 1.
Right.
The step 2 is you see in the lateral gaze, in the right gaze or the left gaze. So the easy way, if you cannot remember that which muscle moves how, which is very difficult, you see if it is in the right gaze, you mark on the right side. If it is on the left gaze, you mark on the left side. You make this column and then mark on the right side and the left side. Then the third step is on the head tilt to the right side and the head tilt to the left side to see whether the extorters are more paralytic or the intorters. So easy way to remember is if it is on the right side, you have to mark the right. If it is on the left, you mark it like this. So the part which comes in all the three is the one which is the underacting, which is a common muscle, which is the paralytic muscle. The treatment for concomitant squints is first treat the primary cause. Until you are unable to treat the primary cause, you have to give a symptomatic treatment to give the patient relief from diplopia. We can give prisms, we can give Botox injections, or we can also operate, but the operating time you have to either wait for 3 continuous same readings or 6 months of its spontaneous recovery and stabilization before you take up for the residual squint surgery. So again, we go back. The approach to a patient with squint is first identify whether it's a true squint or a pseudo squint, then whether it is comitant or incomitant, then if it is comitant, exo or ESO, and accordingly in incomitant, whether it is paralytic, restrictive or mechanical. So I hope at the end, the squint, we have scared the monster rather than getting scared from the monster. And I thank you all for being here.
Thank you.
Thank you so much, ma'am.
Thank you.
Thank
Thanks
you,
a lot.
Dr. Sapna.
Thank you so
Yeah.
It is
Thanks a lot.
So much information.
Madhurima for
And-
arranging this.
Yeah.
Thank you, ma'am.
Thank you.
Yeah,
for-
yeah.
Thanks,
Thank you,
Madhurima.
both of you.
You
Both of
can share whatever questions you want on my personal chat also, and
Sure.
anything else, especially the FRCS students, if they want anything, I'll be more than happy to help.
Thank you so much, ma'am.
Thank you so much, ma'am. It
Thank
was a
you.
very great class. I mean, condensing such a big topic into a small class, it takes a real talent. So, thank you so
Thank
much
you.
for this.
Thank you.
Good night.
Have a good
Thank you,
night,
ma'am.
everyone.
Bye.
Good night, everybody.
Bye. Good night.
Good night.